Today we are going to start a new chapter that is disorder of the menstrual cycle, in which the first topic is heavy menstrual bleed. So heavy menstrual bleed is defined as the blood loss of more than 80 ml per period per several consecutive cycle is known as heavy menstrual bleed. However, per clinical diagnosis, the patient's own perception of blood loss is paper. Now let's talk about the etiology of the heavy menstrual bleed. So the causes include polyps, adenomyosis, leukemia, which is also known as fibroids, the malignancies such as endometrial carcinoma, cervical carcinoma, coagulation disorders like hemophilia or von Willebrand diseases, certain ovulatory disorders that may lead to the heavy menstrual bleed. Also, the endometrial hyperplasia, they may causes endometrial bleeding, and the iatrogenic causes such as a patient under anticoagulant therapy like warfarin or heparin, and the non-classified causes include thyroid disorder. So a patient having thyroid disease may causes heavy menstrual bleed. Now let's talk about some important definition. The first one is heavy menstrual bleed, which is the excessive blood loss of more than 80 ml per cycle per several consecutive cycle. The intermenstrual bleed is defined as the bleeding in between the period. Uh, Oligomenorrhea is the cycle that occur at more than 35 days interval, whereas polymenorrhea is the cycle which occur at less than 21 days interval, whereas the postcoital bleeding is the bleeding that occur after intercourse. And the postmenopausal bleeding is defined as the bleeding that occur after 12 months of menopause. And the last one is the bleeding of endometrial origin. So bleeding of endometrial origin is also known as dysfunctional uterine bleeding, and it is a diagnosis of exclusion of after all other causes have been ruled out. And the bleeding of endometrial origin is defined as the abnormal uterine bleeding of any type, that is oligomenorrhea, polymenorrhea, or menorrhagia, that occur in the absence of any known organic cause of pelvic pathology or any other medical condition. So when no other cause has been identified and there is a bleeding occur, so it is known as the bleeding of endometrial origin. Now let's talk about the clinical features. So the most important hallmark is a regular and excessive menstrual blood loss that occur over several consecutive cycle. It is the main feature of heavy menstrual bleed, and the associated symptoms like symptoms that are suggestive of endometrial and cervical abnormalities include irregular bleed, intermenstrual bleed, and the postcoital bleed, whereas the symptoms that are suggestive of the coagulation disorders, so they include excessive bruising, bleeding from the other sides like bleeding from the nose, the bleeding that occur after dental extraction, if there is a history of postpartum hemorrhages, or if there is any family history of bleeding disorder in the family. Now, the symptoms that are the suggestive of fibroids are the pressure symptoms that include urinary symptoms or symptoms of abdominal mass or abdominal fullness, and the symptoms suggestive of ileic inflammatory disease include history of vaginal discharge. And a patient having thyroid disease, they have symptoms of weight changes, skin changes, fatigue, etc. And the signs that are suggestive of heavy menstrual bleed include the patient may have signs of anemia like conjunctival pallor or chylonychia. The abdominal pelvic examination is usually normal, but in case of fibroids, there may be an enlarged uterus occur. And also look for the signs after pregnancy. In case of heavy menstrual bleed, they are usually absent. Now let's talk about the investigation done in case of heavy menstrual bleed. The first one is the we do urine pregnancy test to exclude the pregnancy. Then we do complete blood count, in which we assess the hemoglobin level and the RBC count. And similarly, we also do thyroid function test, in which we check the T3, T4, and TSH. And similarly, we also do a coagulation profile, in which we check the prothrombin time, APT, and international normalization ratio to assess for any history of coagulation disorder. Similarly, we also do the sexually transmitted disease screening. Similarly, we also do the hormonal testing, and we also do the transvaginal ultrasound to assess for any structural abnormality. And similarly, we also do the high vaginal swab and the endocervical swab. And at last, we also do the hysteroscopy and the endometrial biopsy. And the indication for the hysteroscopy endometrial biopsy biopsy a patient who present with a history of postmenopausal bleed and the endometrial thickness of more than 4 mm on transvaginal ultrasound. A patient having a history of heavy menstrual bleed and the age is more than 45. A patient having heavy menstrual bleed and a history of intermenstrual bleed. There is failure to respond to the treatment. There are any prior ablative techniques done for the treatment of heavy menstrual bleed. Medical treatment and the surgical treatment option. First one is the medical treatment. So we have drugs that are compatible with ongoing attempts at conception, and they are used for controlling the symptoms like NSAIDs and tranexamic acid. Tranexamic acid is used to control the bleeding, and similarly we have drugs that are used as a contraceptives, but they are also helpful in the treatment of menorrhagia, and they include combine oral contraceptive pills and the levonorgestrel intrauterine devices. So the first one is tranexamic acid. Tranexamic acid is an antifibrinolytic agent, and it inhibits the passage of fibrinolysis and hence control the bleeding. And it is safe, non-hormonal, and non-contraceptive drug, and it is associated with the reduction in the menstrual blood loss by 50%. But the disadvantage is that tranexamic acid is associated with increasing risk of venous thrombosis, and similarly they also causes leg cramp and the minor GI upset. The second drug is the NSAIDs. The NSAIDs include aspirin and the mefenamic acid, and these NSAIDs are used for the symptom control, and similarly they also restore the imbalanced endometrial prostaglandin synthesis, and they are also safe, non-hormonal, and non-contraceptives, and they are associated with the mean reduction in the menstrual blood loss by 30%. And similarly, to control bleeding, we also give hemostatic agents. The most important is the ethoxylate. Next one is the combined oral contraceptive pills. So the combined oral contraceptive pills are widely used for the treatment of the menorrhagia. So because the combined oral contraceptive pills, they reduces the bleeding, and they also provide contraception. But the COCPs, they are associated with increasing risk of thromboembolism, stroke, and cardiovascular diseases, and similarly they also increasing the risk of breast cancer. So combined oral contraceptive pills are used both as a for the purpose of contraception and also for the control of heavy menstrual bleeding. Next is the levonorgestrel intrauterine device. So it has revolutionized the treatment of heavy menstrual bleed because it is associated with a mean reduction in the blood loss by 90% in 12 months, and it is highly effective and alternative to a surgical treatment with a fewer side effects. So levonorgestrel intrauterine device system is effective in the control of heavy menstrual bleed. The disadvantages include they may cause irregular menses for the first 3 to 6 months after insertion, and they are not suitable for a woman who wishes to conceive. And the progesteronic side effects include breast tenderness, acne, erratic menstrual bleeding, and ovarian cyst. Next one is the surgical treatment. So surgery should be preserved for the women who fail to respond to the medical treatment and the women who have completed their families. And the surgical options include endometrial ablation and the hysterectomy. First one is the endometrial ablation. Endometrial ablation involves the destruction of the basal layer of the endometrium and prevents its regeneration. And all the women with a heavy menstrual bleed should be encouraged to consider the endometrial ablation before optioning for the hysterectomy. And ablation is suitable for women with a uterus that is less than 10 week size and with a fibroid that is less than 10 that is less than 3 centimeter in size. Now let's talk about the different techniques for the endometrial ablation. The first generation technique, they include the transcervical resection of the endometrium, but they are now replaced by the newer techniques. The second generation techniques, they include impedance control endometrial ablation, thermal uterine balloon therapy, and the microwave ablation. And the post-surgical effects after endometrial ablation, 40% of the women become amenorrheic, whereas the 40% of the women have reduced blood loss, while the 20% of the women have no effect. And the complication of endometrial ablation include hemorrhages. Hemorrhages are most common, increasing risk of infection, and there is increasing risk of the uterine perforation with the endometrial ablation procedure. The next common procedure is the hysterectomy, and hysterectomy involves the surgical removal of the uterus, and it is the only guarantee cure for the heavy menstrual bleed. But trials have shown that hysterectomy is associated with a high risk of morbidity, longer recovery, and more financial cost compared to the endometrial ablation. And hysterectomy is also accompanied by bilateral operectomy, which involves the removal of both the ovaries to reduces the risk of ovarian cancer. And the types of hysterectomy involves total hysterectomy, in which the uterine cervix along with the uterus is removed, and it is a time consuming procedure and there is a high risk of bladder injury. And next one is the subtotal hysterectomy. In subtotal hysterectomy, the cervix is preserved while the uterus is removed, and it is a quicker procedure and had a low risk of the bladder injury. And the methods of the routes of hysterectomy involve abdominal hysterectomy, vaginal hysterectomy, in which we use the vaginal route, or laparoscopic hysterectomy. Now, the heavy menstrual bleed caused by the fibroids. So, the treatment option include medical treatment that involve the use of combined oral contraceptives, transaminic acids, and the surgical option include uterine artery embolization, transcervical resection of the fibroid, and the myomectomy. Now let's talk about the management of the acute severe bleeding. So first of all, in such case, admit the patient, reassure the patient, take a detailed history, and perform per abdominal and pelvic examination and investigation. Do complete blood count, coagulation profile, and biochemistry. Do blood urea nitrogen and creatinine and serum electrolytes. Similarly, maintain a large bore IV line and resuscitate the patient by giving him IV fluid, and if the patient need blood transfusion, transfuse the blood. Then for control of bleeding, give the patient tranexamic acid, and also give have the high dose of progesterone to control bleeding. Once the patient is stabilized, then perform the transvaginal ultrasound to identify the cause, and then treat the patient accordingly by offering him either the medical treatment or the surgical treatments, which include the endometrial ablation or the hysterectomy.